All right. Good morning, everyone. Welcome. We're glad that you're finding us. I think a few more people will probably find us here early on, but we are taping this time so that we can share it with folks later. Just a quick note as you're coming in again, we will be maintaining this is primarily the 4-panel for video and audio, so you should all be able to see and hear. This, if you need to, if you're having a struggle on hearing us, that's something on probably your side, so you need to work on making sure your speakers are there. It's not that we've muted you. We cannot mute your ability to hear. We can only mute the ability for us to hear you. So it's something on your side if that's happening. But we're going to try to help as best we can. And if you're having struggles, don't worry. You'll be able to at least listen later to the video that we're recording. I think most of you know that I'm Darren. I'm the pastor at First Presbyterian Church, and I want to welcome you to this conversation. Again, you can use the chat, and we've also worked to get a lot of good of your questions that were presented ahead of time ready, but we want to get into it relatively quickly. So let me start with a word of prayer, and then we're going to kind of work our way forward from there. So let us pray. Dear God, on this sunny and warm day in May, we are mindful both of the beauty of your world, but also the challenge that we are facing as a world and as a community. As we discuss the challenges of this pandemic and how it works with our church and with our community and with our individual selves and families, help us to also see your light and your love within the midst of this challenge. We pray this in Christ's holy name. Amen. All right, friends, I actually would like to invite our panelists to introduce themselves, but as they do, that gives you an opportunity to hear a little bit more from them and to know something about where we begin. So I'm going to begin with the House family who is with us.
Okay, I'll start off. I'm Dan House. I'm a pathologist, and a large part of pathology is medical laboratory testing, and that's primarily why I'm here.
And I'm Mary House. My career has been in surgical nursing, both working with the surgeons in surgery as well as the office.
So welcome, Dan and Mary. Glad to have you. And now the Voss family.
Hi, good morning, everyone. I'm Pete Voss. I am the current Chief Medical Officer for IU Health here in Muncie in the region for Ball Hospital, Jay County Hospital, and Black Hospital, as well as over the 40 physician offices and pharmacy, and helping Dan some with laboratory things. So glad to be here.
Glad to have you.
I was going to say, I'm Franky Voss. I'm a gynecologist at the Voss Center for Women and have been here for a really long time and get to listen to everything he tells me every day about COVID-19, which is why I'm here.
Welcome, both of you. Glad to have you. Jonathan.
Hi, I'm Jonathan Schmidt, ear, nose, and throat doctor. Actually, Lynn probably knows more about this than I do, and she, like Peter, is deluged in it, but she's at another meeting about this right now. ENT doctors care particularly about this. We're the ones called on, if necessary, to do tracheostomies, and that's the procedure most likely transmit the disease. The other interesting thing though about ENT is we've just recently discovered loss of sense of smell is another symptom.
Right. Yeah. Well, glad to have the 5 of you here. I am definitely just going to share some questions and let your insights be the driving factor here. But I thought we would probably want to start with just a quick kind of update about where we are now, thinking about, with the symptoms that we should be aware of, and maybe some of the statistics that lead us, especially as we focus into Indiana and into Delaware County. I thought I'd start that then with you, Pete.
Okay, so a lot of things about symptoms, and I think Dr. Schmidt already alluded to some of the new interesting ones. Everyone heard starting off with the concerns about having a shortness of breath or a severe cough or having a high fever chills, shaking chills, muscle pains, headaches, sore throat, and newly the loss of smell or loss of taste. There are also some links to stomach pains and diarrhea, and in some of the younger population, even what's been heard is the COVID toe or discoloration in the feet. I think the takeaway message there is should you be concerned, and I think particularly anytime that you have enough of a shortness of breath or high enough fever where you don't feel well or safe, clearly you should seek medical care. And if you have some of the symptoms, the first place always to start is with your doctor. That's the first place to start. The hospital, the emergency room is always available if you feel like you're in danger. But those are the main symptoms. And I think the key is focusing on the difficulty breathing is the main thing. And I'm sure some folks may have other questions there, but that's the overview. As far as what's happening, clearly we're inundated with our newspapers and CNN and Fox News and all those things, so there's probably updated tickers, but the US had the inauspicious number that we passed 1 million positive cases this week and over 60,000 deaths, nearly 63,000 deaths. Indiana has been somewhat less affected. I would make the comment, when you hear about positive cases are also very much impacted by the number of tests we do. So, and the reality is most states are only testing 1% to 2% of their population. So right now in Indiana, we've had close to 18,000 positive cases, and we just passed 1,000 deaths in the state. Here locally for us in Delaware County, we've only had 185 residents test positive. That's very much in part to difficulty to getting testing. But on a positive note, it's never good to talk about deaths. We've only had 17 deaths in our county compared to many other counties in Indiana. It's a very low number. So that is at least somewhat positive. The last comment I'll make there, people say, well, we read about the spike or flattening of the curve or what is happening, and we have seen a very much the term flattening of the curve. We still have quite a few positive patients in the community that are quarantined, but also in the hospital and some in critical care. And so we are in that phase, what they call flattening or slowly declining of the curve. And we've seen that consistently now for almost 3 weeks. So that is a little bit of optimism. And that's why later when we hear about Governor Holcomb opening the state back up and what can we do, that's one of the key things that has had to happen, is that gradually declining of numbers. So my last word is we're not done. There's still positive cases every day. There's still more testing, but at least there is a glimmer of optimism that the numbers are going down and the seriously ill people that need to be in any of our hospitals are declining across the state.
Great. And before I move on to any others want to add a bit on the overview or synopsis?
Excellent.
Yeah, thank you. Thank you, Pete. So as we're looking to one of the things you brought up then is around testing, and maybe a good lead in is one of the questions that was presented. Lance Schultz asked that he was hospitalized earlier this year in February and March, 3 different times, and all of the times one of the major issues was the inability to breathe each time. And so his question was around antibodies and whether antibody testing, when might it be available, and with that also, who should be tested? Someone who, like him, who has had some symptoms right before maybe all of this has kind of happened, or who are the right people to be tested when antibody testing might be available? So you may not be able to answer that direct question, Dan, but can you help us a little bit thinking about testing right now and about the different things that are going on currently and are coming in the forward as days move forward?
Sure, Darren. I think I will choose to talk quite a bit about testing, and the reason is that so many different issues surrounding this pandemic hinge upon testing. Pete has already mentioned the difficulty in getting tests. Governors have had lots of problems ramping this up. It's it's going to be a big issue in our opening things back up because testing precedes contact tracing. So I would like to begin just by describing what the current test is like that we're doing. The key word here is that this is a very complex test. It is a test that is done in the laboratory by looking for tiny little sequences of RNA. That's genetic material that comes only from this virus. It's unique to this virus. It's only a few molecules, and the test that we do looks for those molecules, and when they are present, then the test chemically converts those to DNA, and then the DNA is expanded. The problem is these are all just molecules. They cannot be seen. And so the DNA is again treated chemically to produce a longer chain that's called a polymer. So the whole test is called polymerase chain reaction. By building these chains, we magnify the little viral RNA 100,000 times until it can be detected. Now that type of test has some very great advantages, and it also has some very great disadvantages. The advantage has to do with specificity, that since no other organism in the world has the unique RNA associated with this virus, if it's present and you amplify it and detect it, theoretically that test is going to be 100% specific. That means that if you have a cold or the flu, those viruses will not be amplified by this test. And so there are no big problems with false positives. The disadvantage of this test is how complex it is. It needs to be done in a laboratory that is certified for complex testing. The people that do the test, the technicians, also have to be certified to be able to do complex testing. And so this is not an easy test to do. It takes hours in length, not minutes. And then the other problem with this test and the difficulty is that obtaining the sample is also problematic. Obtaining the sample requires a swab. It is not just a Q-tip. This is a special swab. The tip of it is either calcium alginate. It could be Dacron, it could be nylon, but it can't be just cotton. The swab is inserted into the nose, and it's pushed all the way back to the back of the nose until it hits the throat, some 4.5 or 5 inches. And Jonathan, correct me if I'm wrong about that. One thing I can tell you, because I've done many of these tests on little kids, is that 100% of little kids cry. And 100% of adults will cough and sneeze and gag and do other unpleasant things right down the front of you. So these tests require protective equipment for the person doing the test. The swab is then immediately placed in a vial of viral transport media. It can't be water, it can't be saline, it has to be viral transport media. That has a shelf life of 3 days. So it needs to get to the laboratory very quickly to be run. What I just described is the reason why when a governor says, oh, glory day, I just found 100,000 new test kits. Well, that's great, but that is not all that's necessary to implement those tests. In order to ramp up this type of testing, what you're really doing is ramping up a test infrastructure. And it has to involve all of the elements that I just described. And so that is one of the big problems that we're having nationwide to get this type of testing done. So that will allow me to segue into another question that has been submitted, and that is, what about the rapid tests? The ones that are much easier, much quicker. There's one such test system that's being marketed by Abbott, the Abbott company. And let me start this by repeating an old joke. You've all heard it. The joke goes like this. A man goes into an automotive repair shop, and before he can even talk to the manager, he sees a sign up on the wall, and it says, you can have it cheap, you can have it fast, or you can have it correct. And then down at the bottom, it says, choose only one. Well, that's very pertinent to this testing question. The Abbott test is faster, it's easier, but it is not as accurate. Okay. It would be wonderful to have point of care testing in this situation. That means a test that can be performed in the doctor's office, in the field. That would be just wonderful. In addition, this test does not require a nasopharyngeal swab. It can just be put in the mouth. That is one of the reasons, though, why the accuracy that Abbott advertises is only 87%. Now, they did not give us the actual data. So the scientists out there, I can't tell you what the specificity is or the sensitivity. I can only tell you that it's 87% accurate. In my opinion, that's not quite enough, and I will illustrate it with a real example. The White House was given one of these Abbott machines. It's a desktop machine, and they gave it to the White House with the appropriate reagents so that they could use it. It is White House policy that every person that sees the president has to be tested every day. That means secretaries, aides, staff, anybody visiting has to be tested every time they come. That could easily be 20 tests a day, and over a week, that's over 100 tests. Using this machine, 13 of those tests will be wrong. Now that may be good enough for the president, but that's not good enough for this laboratory. That is too risky as far as I'm concerned. There will come a time when the point of care testing is more accurate, but that will take time. Now, to go to Lance's question about antibodies, this is a tough discussion. It's a complicated area. It's something we very much need. This is a test that would not just tell you if the virus is present or not. It would tell you whether you've recently had the virus or whether you have completely gotten over it. That would be wonderful. We absolutely need that information to open our country back up. Unfortunately, we now have 47 different antibody tests that are out there. We are in a very odd circumstance at this time. Testing and the making of new tests is usually a highly scripted, highly regulated process, so that you as a consumer can be assured that any test you take is accurate. We're not in that environment. We're in kind of a Wild West sort of environment where 100 different laboratories are trying to develop these tests, some of which are good, some of which are not, and we really don't have the validation data as yet to tell which is which. So that is coming. It will be here eventually, and it will be a very necessary part of conquering this problem. That's probably all I need to say about testing.
Sure, thank you. And I think that leads us to some of the things that and this will have the opportunity to kind of give some feedback there. But one of the questions was around antibodies and immunities, and a lot of questions I think that folks are having around it is this idea that Eileen Howard shares, which is asking really about the idea of herd immunity. And if that makes any difference right now, or if that will make, if we know enough to know if that's part of what may happen. So Jonathan, I know we were going to talk a little bit about vaccines and immunities, and maybe in that conversation, you can share a little bit about what you might know around the possibility of herd immunity in this case.
Sure, Darren. My definition of herd immunity is that enough people have it that the disease won't get out of hand. My analogy is a nuclear reactor. It's putting out nuclear particles all the time, but you have control rods that keep it from getting out of hand. If you need a bigger reaction, you withdraw some of the control rods. You never would possibly think of removing them entirely. You would have nuclear meltdown or a chain reaction that was a bomb. Herd immunity, in my mind, are the control rods. And the more you have it, the better for tamping down the process from getting out of hand. Unfortunately, you mentioned about a vaccine. From what I've read, it could easily be a year. And all of us started our careers, I think I can say, in the 80s. Back at that time, actually, Lynn and I met at Henry Ford Hospital, and it was a regional AIDS referral center. Other hospitals were quite agreeable to sending their AIDS patients to us. And if you think about almost 40 years, we still don't have a vaccine for AIDS. We don't have a cure for AIDS. We have some medicines that we can treat it and improve people's longevity and quality of life, but there's no cure. There's no vaccine. Even the vaccines that we have for diseases that we know, for instance, if you get a rusty nail, you'd like to have a typhoid so you don't get tetanus vaccination. Well, you need a booster if it's been, I think, 7 years. So that's not lifelong immunity. I did want to back up for Dan just a minute. A few years ago, I was Michigan's third bird flu positive patient. And I got the nasopharyngeal swab. And I still to this day remember thinking that was a miserable process.
Yeah.
So yeah, it's not a fun thing, but I see why you have to do it. It'd be much nicer if it's just right inside the nares, but it's not. Right. There was a question put forth. If you have it and you get over it, do you have immunity for life? No one knows. I would pray to God that if you go through such a miserable process, you deserve immunity for life, but you might not. We just haven't had a long enough track record to answer that question, I think.
Right. Yeah. So one of the things, and you kind of alluded to this, Jonathan, and so I'll let you kind of start this piece too. And it's a question I just received this morning. Mike McCulley asked, he's received a flu shot as he does on an annual basis. He's received his 5-year pneumonia shot and is still within that 5-year time. And his question was, do these actually make any difference to the severity, the possibility of the symptoms of coronavirus? Is if you have a history, like he suggests, of pneumonia, does that make you more susceptible to severe symptoms with the coronavirus? I'll take that a little bit further. I know that there's been a conversation about one of the medications, one of the two medications that were listed early on. One of them, I don't pretend to remember names on this, but one of them has been kind of showing either no or even negative, but one right now has been showing at least a reduced length of severity for patients. Can you share a little bit around medications and then maybe a little bit on the flu shot, the pneumonia, and people who have maybe a history of pneumonia and how that may affect this situation?
Certainly. Bear in mind, I'm a surgeon, so take it with a grain of salt.
Yes.
I can't encourage enough, get whatever vaccinations are out there, get your flu shot, get your pneumonia shot. And that's actually worth talking about for a moment too. There's a whole host of different influenza variants, and they're always trying to cover as many as possible, but it changes every year. This one just sort of came out of China, but it's very important that people, and particularly those are usually aimed at a more vulnerable population. So by definition, sorry, Mike, age is one of them, but if you have any cardiopulmonary or immunocompromised status, you want to get those vaccinations. Now, will they help protect you from COVID-19? Not a bit. I don't think there's any research to show that.
Right.
In terms of medications, I haven't looked at it for a while. I'm sure you guys remember it. It was an anti-malarial one. And the data, normally in science, particularly medicine, we pride ourselves on, just as Dan alluded to, a lengthy, rigorous investigation of things. Mm-hmm. But when you've got people dying on a ventilator, you're willing to try just about anything. So they tried that, and I don't think the data is very supportive of it. Now, there's another medicine called remdesivir. It is the one I believe you alluded to. It shortens the duration by about 4 days. Well, getting it down to 11 days instead of 15 or so days is a godsend. That's huge.
Sure.
Interesting little footnote about that. The company, Gilead, that produced it is the same one that produced a medicine for hepatitis C, and they were widely chastised because they did charge $84,000. But curing someone essentially hepatitis C not only saves their life, it saves a lot more than $84,000 down the road. But with this medicine showing promise, they donated their entire stock, 1.5 million doses. And if you think about it, not that they would have, I suppose, they could have made an awful lot of money out of that 1.5 million doses. So that's not all corporate greed out there. I was rather impressed.
Yeah, it's good to have that positive. Pete, you might have, I don't know if you have anything to add to that bit.
Sure. So for medications, obviously from early on, and sometimes again, what we hear in the news, the anti-malarial medicine, the hydrochloroquine was highly touted. That's what Jonathan was talking about, as well as even an antibiotic, azithromycin, or what people know as a Z-Pak. Those were early darlings of this and really have found to have no effect. And as a matter of fact, in some folks, a detrimental effect. So they've been fairly strongly taken out of the equation after several 100,000 patient exposures and experiences. What Jonathan was alluding to with the antiviral medicine, remdesivir, those are the very first early studies that have just come out where it may shorten the duration of the serious part of the illness. Haven't shown the difference in deaths yet. A lot of discussion about, and it might seem silly to talk about, but every day somebody's saying, well, this might work and this might work. So there's some from all of us as physicians and medical people, taking Pepcid or anti-ulcer medicines is not something that's helpful. So you hear a lot of these things. The challenge with this is we don't have one clear treatment. The treatment is time and support. And honestly, the most important medicine is oxygen. That is the most important medicine here, whether if you can't carry enough oxygen because of damage to your lungs and the little alveoli, the little air sacs, then it's getting support with oxygen. It's not so much, interestingly, often when we're sick or somebody has the flu and they're dehydrated, they get intravenous fluids. That's actually been found to be detrimental. So it's really, if you're sick enough that you can't carry enough oxygen, that's where you seek care and get oxygen with the prongs on your nose to try to keep your oxygen levels up. And if that's not enough, that's what Jonathan was alluding to, either a breathing tube or even the extreme of having to have an opening in the neck to have support to breathe for you. So medicines, lots of theories and lots of studies. There are a lot of things going on, but no clear winner. So cautious optimism with what Jonathan said with the antiviral medicine, more to come.
So Pete, keeping with that, then thinking about how are our local hospitals, Ball Memorial and the other two that you work with, how are they doing with the PPE, with ICU beds, ventilators? How are the staff doing? Just a little update just from where our hospitals are right now.
Well, I will just say, to start with, we are blessed. We are blessed with our community support. We are blessed with our hospital system, our towns. It's just humbling to see, and all of the incredible overcrowding and just really heart-wrenching stories you hear, not only overseas, but in New York and some of the other places. We have not experienced that. There have been 2 or 3 hospitals in the state that really pushed their capabilities, but at Ball Hospital and even at Jay and Blackford and the other hospitals in the region, we have not been overrun. We have had patients in our critical care units. We've had patients on the ventilators. We've had patients pass away, but we have had more than enough supplies and staff. People always want to know about the number of ventilators. We're one of the unique places in the country where we probably had 80% excess capacity and ready. We have enough people with ingenuity that they've cobbled together old machines to be on standby, converted to anesthesia machines. And so even here in Muncie, we would have been able to take care of nearly 100 people at a time on the ventilator, and the most we've had is in the 20s. So really blessed there, also with the staff, just an unbelievable dedication of the staff being on those front lines. There is some physical fatigue and clearly mental and emotional fatigue. One of the things I can't overstate is just the toll that it takes, because often these people that are critically ill need to be isolated, so you don't have the social interaction. You can't have the family members at the bedside. It's very challenging to show that compassionate side of care and be there all the time. So taking a toll there. The biggest thing that you hear all about is the protective equipment, personal protective equipment, the gowns, the masks, the eyewear. We've also been very blessed there that we have been planning ahead and have gone through these type of pandemics before. So as of Friday, I think we still had 9 or 10 months of supply on hand to take care of those. But we have to be very good stewards of those resources and make sure we use appropriate levels of gowns and masks and gloves and eyewear, depending on the risk to the patient. That you hear a lot about healthcare workers being fearful that they might not have enough protection. Interestingly, we've had no healthcare workers admitted to the hospital or into the critical care unit, despite 12-hour shifts, day after day after day, taking care of these folks. So we've been blessed and we've been lucky. Darren, you asked the question, what can people do? We get a lot of questions about masks. Can we make masks? Can we donate things or otherwise? And I think the way to think about masks is sort of in three different levels. There's the very fancy, what they call N95 respirator masks that can really protect down to the smallest particles, down to the size of the coronavirus particles, if they're appropriately fitted around the face. Then there are the regular surgical masks that you'd see very commonly if you went into your doctor's office, dentist office, or in surgery. And those are effective, but not in high risk procedures like Jonathan alluded to earlier, when you're working with the throat and creating aerosol and cough. And then the third is cloth masks, that things people are making, or even to the point of bandanas. And I think in a healthcare setting, surgical masks are probably the minimum safety protection. And if you go into any office or in the hospital, you'll be given a mask to wear. The cloth mask, while wonderful and helpful, I think will be much more useful in the next month or two out in public, because not everybody has a surgical mask at their house or can buy it at Payless or Meijer or Walmart. So I think if there are cloth masks and we are to protect ourselves, those are masks that people can use if they're going to the grocery store or out in a public place. And there's a lot about making sure that they're washed regularly in the washing machine or otherwise. But donations of homemade masks to the hospital, probably not as important. So those are things, but we've been very blessed. I think the other thing that people need to be aware of when they talk, how can we help? The hospitals received a whole bunch of food. So, all of us, even as Presbyterians, we love to make food or have a carry-in. So food is always welcome. But I think the behind the scenes thing that I think we all need to be ready to support for, besides just praying for the team members and the patients, is the upcoming or looming issues we're going to have with mental health and depression and anxiety and substance abuse. We are starting to see that because people are isolated, they're home, they're anxious, and they're turning to other things, and the support systems are not as easily accessible. So as we work through this coronavirus pandemic, a second issue that we cannot forget is that support. So if we have the ability or resources to support any of those entities, there's going to be a huge need for that.
Thanks. Thank you. There's been a question, Mary, about nursing, and maybe with some of your contacts within the nursing community, you might just share a little bit of Bob and Julie Wadsworth are asking about how can we support our nurses that are in our hospitals and in our nursing homes. So you might address that, and maybe if you want to share a little bit about kind of where things might be, at least from your perspective, what you know about our local nursing homes.
Are you talking to me, Darren?
Yes, Mary.
Okay.
Sorry.
Okay. So first off, I know people are wondering, why do we need so much quantity of PPEs? You have to understand that after you see every patient, after a nurse or doctor, whoever, leaves a patient room, they have to take all the PPE off, and there's no way that you can't that you can be absolutely positive that you don't transfer some of the bacteria, some of the virus onto your skin. So you must go wash thoroughly your hands, and you must then, before going into another patient's room, do the whole process again, don the PPEs. And it's not an easy thing to do, and sometimes you need help. So that's one of the reasons why you have to have so much quantity of the PPEs. And bear in mind, when people are anxious because the nurses don't seem to be Johnny on the spot, there is a time element involved with all that process. And the nurses are there 8 to 10 to 12 hours a day on the same unit. Now, the other thing is, with nursing homes and jails and so forth, these people are already at-risk individuals. Many of them have major health issues, even in jails. Those people have major health issues, and it's a confined atmosphere. All those patients or jailmates, they have people from the outside come in as their caregivers. All those people have families. All those people have relationship with their family that are out in the community. So one thing you can do to really help that atmosphere of at-risk people is if you have any symptoms of the COVID, the flu, any other symptoms, diarrhea, vomiting, do not visit. Even when the restrictions are lifted, that is so important. I know people are eager and anxious to see their loved ones, but if you expose your loved one and everybody that works with your loved one to something you have that's contagious, that's no darn good. So you really have to be careful of that. And one other thing I want to address with event things, we are now, I understand, using an old treatment that used to be used for cystic fibrosis kids. It's called cupping. And that's a procedure where you cup your hand and hit them on the back or the chest to help break up the phlegm that's in their lungs and to expel that, because the more you have of the mucus and so forth that doesn't get away from your lung, the harder it is to breathe. So those are some of the things. Just remember, no matter how much you want to see your loved one, if you bring in more problems than you are getting treated for, than they are getting treated for, that's the wrong attitude.
Thank you. It's helpful because especially that turns us really to, I think, what the governor has been working with us, not just yesterday, but over the last, 6 weeks, 7 weeks, but especially yesterday. I think a lot of new questions are in how things, how the governor's kind of beginning to open the state of Indiana and how that affects. So John Mall asked, do you think the governor is moving at the right speed, too fast or too slow in returning us to normal, is what his question was. And I think that lends us really to thinking about how as we begin to open up businesses and churches and restaurants, what do we need to be doing differently ourselves, and how do we react to the information that the governor has given us? So Franky, can you give us a little bit of insight as we move forward with the input from our governor and how we best live into stage 2, as he has called it?
I think a lot of people have a great deal of trepidation about now what, we've been on lockdown, we've been told to not go anywhere unless we have to, and now all of a sudden, maybe not the green light is on, but the yellow light is like, okay, proceed with caution. And some people are going to disregard everything and say, hey, I don't have a stay-at-home order anymore, and I'm gone and I'm out and I'm doing whatever I want to do. Obviously, that's not the right thing. I think that if you read the governor's plan, and if anybody does not have the entire plan, you can go to online. The address is backontrack.in.gov. And he has a 24-page, something like a 24-page outline, step-by-step, stages 1 through 5 of all of the plan. And I think that, Pete and I read through this last night, and I think that if people actually follow the plan, that it seems appropriate. But how do you police things to say that they are actually doing all of the things in the plan, in the steps, that he outlined? So, as of present, until Monday, it was no more gatherings over 10 people and that type of a thing. But as of Monday, all of a sudden it's 25 people. And then May 24th, it's 100 people. And June 14th, it's 250 people. And then as of July 4th, it's a free-for-all. Maybe not quite a free-for-all, but you know what I mean. So
Yes.
I'm thinking Colts games is what I'm thinking. No, anyway. But he was very detailed in his outline of how we should proceed. And, you know, saying that a restaurant or a facility where you can shop and buy clothes should be at 25% capacity. But who polices that? And to be honest with you, the answer should be us. Each as an individual, we should police ourselves. We should act logically, thoughtfully. I think it's super important that, you know, the first time I went to the grocery store with a mask on, I felt so silly. I felt, okay, I feel like I'm overreacting. I look ridiculous, whatever. But, you know, now I've done it multiple times because I'm shopping for our moms also. And it's, you know what, I'm like, no, this is the right thing to do. And now it feels fine. You know, I think if you plan on traveling, you certainly should be wearing a mask. The time where he said face covering would be optional would be June 14th. But he really suggests that until June 14th, everyone should be wearing a mask outside the house. I mean, unless you're exercising or whatever. If you're in any kind of a social or store or any type of situation where you're exposed to the public, you should be wearing a mask, no matter how silly you feel. And it's okay if it's a bandana or a homemade mask or anything, but it's the precaution that you should take, not only to protect yourself, but in case you have a little bit of, you could be an asymptomatic shedder, you're helping protect others. So I think that that's really important. I think that we as a church, you know, if whenever the session decides that we want to go offline instead of online, then we need to be really cognizant of who should be coming to church. You know, perhaps people with major health problems shouldn't be coming and should continue to do online. And when we do come to church, if we're in good health, we probably should wear masks even to protect one another. We're not going to have our passing of the peace, at least close up. And when we're sitting in the pews, we should spread out, you know. We've got a nice big church with lots of pew space, and we need to be cognizant of that. And I think with travel, you know, that's been another thing that people have said, you know, when can I actually go somewhere? When can I actually travel? And we were joking the other day that probably right now would be one of the best and safest times to travel because nobody's traveling, the airlines are empty, and every hotel is going to tell you how they are keeping their rooms cleaner than any other hotel and cleaner than they've ever been before. So really now is probably a really good time. But at the same time, you know, you shouldn't like go on spring break with 100 or 200 other people on the beach. So like I said, I think that we need to police ourselves and be just mindful. So, and you probably have more to say about that. So.
I was going to say, I think the key to here in all of this, what we'd call ramp up or restart, is also not just the masks here early on, but the social distancing. True in healthcare, starting Monday, we're starting to ramp up surgical procedures. Offices are opening more up, but it will be a different way. If an office visit can be done via what we're doing now via Zoom or chat, we're going to try to keep that even if the COVID virus goes away. The era of a packed waiting room with 40 people waiting to see the provider are probably a good thing, gone of the past. Actually moving chairs apart from each other, having people check in right into a room, those kinds of things. And so it will be perhaps a much slower start or harder to get to, but that doesn't mean if somebody has a critical issue, they aren't going to get taken care of in a timely fashion. But the same thing goes for as we open up all of our restaurants and shops and otherwise. If you are out and about, it's being aware of yourself and socially distancing and all of those things. And as Mary said, if you have symptoms, do not be going out. You know, hand washing. Dr. Franky jokes with me because I'm probably a fast hand washer and she's a slower hand washer. So I've sung happy birthday to myself way more than I have ever in my life because you can sing it twice. That's about the 20 seconds you need with good soap and water. So sing happy birthday to your friend, to yourself, to Darren. You know, so I think that is simple things are really important.
And part of that question also was, do we think that we're going to see a resurgence in this fall? And my guess is yes, we probably will, but we can't stay locked up forever. We can't. for our own mental well-being and also for our economy. We cannot stay locked up forever. But I think that this gradual approach that he's outlining makes sense. But I do think that eventually we probably will see a little bit of an upswing, but hopefully it's a small upswing and nothing that's going to overpower the hospitals like it was in New York City earlier this year.
And that,
can I address
yeah,
that?
please, Jonathan, yeah.
I read an article that Lynn offered for me, and it made an analogy. It says, this could be a blizzard, a one and done. It could be a winter where storms come and go, or it could be an ice age where it lasts and is with us for years. We just don't know yet. But I think Franky's probably right. I think it's going to be a resurgence, hopefully a small one.
Right.
And that leads me to just a brief piece, and I'll keep this very brief because the one place I do have some knowledge on is the church, and I'll share really briefly where the session is at this time. The session is not prepared to open up as quickly as the governor allows, for multiple reasons. One, because a large part of our population is of that at-risk age, and we're very mindful of that. And we don't want to exclude or encourage wrongly folks to come and be gathered yet here within our building. Also because we're not quite ready for that either, both on a making sure that we're ready to social distance within our setting, as well as and having the sanitations and sanitizers and other things like that. But also because we're really working to ramp ourselves up. Most of you will know that we were not digitally sharing worship until this happened. And we've had a wonderful group that is working diligently to do what we're doing now. But what we're doing now won't work as a hybrid model, but we have really been working hard to get ready for that. And so we will keep you informed, but do not plan yet to come back to worship on the 10th of May or after right now. We'll let you know at least a week ahead of time when we're ready to have in-person worship. But please do keep tuning in as you have through our YouTube and through our Facebook pages. We're really trying to keep you connected that way. So just a piece on the church plan. There are a few questions I want to make sure I get to that are from people who posted ahead of time. And so Tom Swartz asked, what do we know about the length of time that the virus lasts on various substances between cardboard, metal, and plastic and wood? And a follow-up question from another person that flows into that. Carol Watkins asked a question about how to handle groceries. And so again, the concern about, does the virus stay on the groceries? Should we be disinfecting groceries? What should we be doing in general when we think about where the virus is resting, laying, and what we should be doing when it comes to cleaning these different things? I don't know who might feel like they might have a good answer on some of that. Maybe it looks like maybe Pete's or Dan. Go ahead and make a shot at it.
Why don't I start off and then the rest of you jump in? There are pretty good studies that have been done about various environmental surfaces in terms of how long the virus stays. And if I were to generalize, what I would say is it really, you can think of it in terms of how long does it take for a droplet of moisture to evaporate. That's a good rule of thumb. It's for that reason that the CDC has told us that getting mail out of your mailbox is not a risk. And their reasoning is that when a droplet that contains viral particles falls on something that's paper, the liquid in that droplet tends to be absorbed very quickly in the paper, and the virus will then sort of dry up, as it were, very quickly. So that's the reason they say mail is okay. On other environmental surfaces like stainless steel or plastic, it takes much longer, maybe up to 3 days, in fact. So it's kind of a variable thing. I like Dr. Fauci's explanation for this. He says that this is a theoretical possibility, getting coronavirus from an environmental surface. It certainly is. And I think, in his opinion, it sort of depends on the amount of contamination that's present. So in a hospital room where things are heavily contaminated, the possibility of transmitting the virus that way is probably fairly high, and that's why we're taking so many precautions. But an isolated sneeze in the presence of some groceries is not likely to produce heavy contamination. And so I don't think that we should be spending a lot of time worrying about that. One of the suggestions that we are following is when we bring things home from the store, we simply leave them out in the car or in the garage for a day or two. That would allow any evaporation that's going to take place to do so. Some people that are reusing PPEs even just put them in a room for 3 or 4 days, and they think that that would do it. So those are just some thoughts to get us started.
Yeah.
Yeah, and one thing I would like to say is please don't wash your vegetables with any chemicals. Just rinse them really well in water. That will suffice. Yeah, don't use any chemicals on your vegetables that you'll be eating. So.
No, that's helpful, because we may, just in an effort to try to make things good, may make things worse.
And to Dan's point, but if there's something that can't wait for 2 or 3 days, whether you have the craving for that Nutter bar or whatever it is, it's okay with that cardboard box or plastic container to externally wipe it off, with the sanitizing wipe. It is okay to do, but I don't think you have to do that with all the things.
Great. Ed and Connie Humphrey sent in the question. They're directing it to Pete and Franky, but it might be any of you. They have they're parents of a daughter and a son-in-law who are expecting their first baby, and the baby's due in early August. And so they're interested in hearing if there's guidelines or considerations or precautions that you would suggest that help with interactions and social distancing with them now. Obviously, as parents or grandparents, we want to see these babies when they show up, and we want to be there for our children. And this goes back to weddings and funeral. I mean, all these important life events that we want to be gathered for. So they're interested really in how they're currently telling their patients, or what are you telling your patients in the situation? We haven't seen them in person for 10 weeks. And of course, would like to see them before and after the baby is born, if it's safe to do so.
Right. And I think a pregnant lady is no different than any other human being right now. Fortunately, this particular virus has not seemed more virulent in pregnant ladies or in infants or children. Actually, infants and children have been very low risk for this particular virus, which is interesting. It makes it unusual. Pregnant women are not in any more risk than the average human being for getting the virus. So I think as far as now, while she's pregnant, the appropriate social distancing, is fine, just like you would treat anybody else. Now, when the baby comes, that's hard. Right now, the CDC says FaceTime. You don't go hold your new grandbaby, and that's really rough. But they don't feel that unless you are living in that household full-time, like, with our stay-at-home order. If obviously we live in the same house, we don't have to wear a mask around each other and we can sit close together. But my mother, who lives down the street, she has not been in our home, and we have not been in her home ever since this began. So that's what, eight weeks or something. I mean, it's hard. And if we can see each other outside, if it's a beautiful day, we will sit 6 to 8 feet apart outside. And it would be the same for a new grandparent. If it's a beautiful day and they can stay far away from the baby and see it at a distance, yes, that's great, but probably until everything is, now, fortunately, theirs isn't due until August when all the restrictions have been lifted. But those people who are having babies right now, really, they're suggesting there is no physical contact or touch, that FaceTime is really what you should do. But hopefully by August, things will be better, and they will be able to hold their grandbaby. And if they want to be super safe, they're going to wear a mask while they're holding their grandbaby. And all pregnant ladies are tested when they come in for labor to know whether there's any risk to the newborn. So everyone is tested 100%.
There was one last question, and I think, Dan, maybe you'll start this and then see if others have some input. And I know this could be a whole hour on its own, so just maybe anything that comes around this. But Sue Desmond was asking about if there's things from the historic pandemics that we know about, you know, whether that's 1918 Spanish flu or any of the others that we're kind of pretty well aware of. Are there things that we can learn about? And I think you've covered a few of those about the idea that it's the likelihood of it coming back, but are there things from the history of pandemics that we've encountered that might tell us something about what we should be expecting as we go forward?
Okay, well, I can start us off. Others probably have comments. Every pandemic that I'm aware of, including the plague, including cholera, including the influenza of 1918, they all have come in waves. With the plague, it was waves over many years, actually. With the influenza of 1918, it appeared in the spring, the early spring of 1918. It was a problem, but not a big problem. It appeared in the summer of 1918, and that was a huge problem. And after that was over, it came back again in the winter. And so many virologists that I've read are expecting a pattern like that. There may be one big difference for those of you that are interested in science. The influenza virus undergoes very rapid and very extensive mutations. And that some people think is the explanation why the second wave, the 1918 flu, was so bad that it had mutated, and it was actually a different virus. In the case of coronavirus, that's not very likely. It could happen, but it's not. What I mean is mutation is not very likely. It probably will come back in waves, but perhaps not in a mutated form. The reason for that is the virus has only a single strand of RNA, and it has a repair enzyme to repair mistakes in translation. The influenza virus, on the other hand, has 8 strands of genetic material, and they can rapidly mutate, mix with each other, and it has no repair function. So it's much more likely to mutate. That's the reason Jonathan mentioned that we have to have a new shot every year, because it mutates so much. So that's a brief answer. We're kind of running out of time.
Yeah, we are. But if there's others, this is the last big question, so then we'll wrap it up from there. But
I just wanted to make a couple comments about that. For perspective, that 1918 influenza killed about 650,000 Americans, and that's out of a much smaller overall population base. I believe we've just crossed, Peter, 100,000.
63.
63. Okay, then every life's precious, of course, but at least that's 10% of what the country went through then. And the majority of those, for whatever reason, were young people in the prime of life. So from trauma to a society, they're far more significant. The other thing I just wanted to mention is go for support. Go YouTube Billy Joel, Always a Nurse. I'll bet you most of us remember Always a Woman to me. It's just humorous and it's wonderful. Every time I listen to it, I get a little choked up. That's all.
No, thank you.
Darren,
Yeah, Pete.
I'll make one comment about Susan's question is very salient about how is this different, and it seems like as we're talking about this particular coronavirus, we're singling out if you're over a certain age or if you have certain risk factors, you need to keep sheltering in place, and we're picking on somebody that's old. And the difference here is with a lot of those previous epidemics, as Dan mentioned, that it affected a lot of young people and kids, and otherwise, interestingly, even with our last H1N1 in 2009, the majority of adults, over a third, already had immunity from that virus before. So even H1N1, that was affecting the pediatrics offices were filled. We were worried about the pregnant women, the young people. So this is what they call a novel virus. None of us that we know of have seen it. And so therefore, the spectrum, interestingly, has shifted to those more frail or at risk or with comorbidities. So what you hear, age is a factor, and the other things, it's not the people that have chronic breathing problems. It's people that have had issues with their high blood pressure, very unique, unusual. People with problems with diabetes. So we're seeing unusual things when we're seeing about people having blood clotting problems or strokes, so some unusual things, even the risk of some heart attacks. So if somebody has not just an age factor, but has significant difficulty with their blood pressure or diabetes or otherwise, or kidney disease is the other big one, those are folks that's the abundance of precaution. Even if we are opening up in these 5 stages, it's a healthy dose of common sense that if you know that you have some risk or a loved one has risk, this is not a race. I said it early on, we're the tortoise here. We're not the hare. We want to be in this for the long haul. I hope Jonathan's Ice Age prediction is not true, but all of us medically think this will be in our communities for at least a year, if not longer, and we have to be ready for that. And so that's what makes this particular virus different, because none of us have had previous exposure, and people are infectious well before they have symptoms. So when you go out and say, I feel fine, you could be that person that carries the virus to somebody else, where a lot of the other things may not, the other influenza type viruses, people may not have been infectious until they had symptoms. So that makes this very difficult. Back to Dan's original point, that's why we need to get that good testing and contact tracing, but we've got a ways to go. And so there's always hope, and hopefully God will show us the way and give us the tools faster than we can hope for.
Darren, can I make one comment
Please do, Mary.
on what Peter said? I've been in contact with Jeannie and Don Fields, and Don's had a bad case of the corona. I want to caution people that even when people recover from the corona, Don has been requested by his healthcare workers in Florida to have no company at home for at least 2 months, perhaps 3. So just don't be rushing to see people after they have recovered from the corona.
That's very helpful to have in this.
And one final point that I read this morning, a point of hope, just an interesting idea. The plague occurred in the Middle Ages, the Dark Ages, as it were, and it was immediately followed by the Renaissance. So let's look for that.
I think that's great. Well, and I tell you what, just as a leader here at a church, just like I think all of us that are in leadership or in business ownership or wherever we may be, if we're in some type of leadership, we have already been being pushed to move ourselves forward. And I think that's part of this renaissance that we may be living into. And I know that will move us forward. Thank you all. Thank you, Mary and Dan House. Thank you, Franky and Pete Voss. Thank you, Jonathan Schmidt. We are glad and thankful that you are not only able to share with us, but that you're part of this community, and that you're able to continue to give us insight and hope. Know that we are praying for the 5 of you, of course, but also for all of our medical professionals, our chaplains. We know that everyone, even if our numbers thankfully are low, there is a lot of stress, a lot of anxiety, and a lot of challenge, especially within the medical field. And so we are keeping you in our prayers. And as a church, if we can be of support, know that you can reach out to us, and we will try to do that. Thank you, all of you that have been listening in, and those of you that shared questions. We appreciate it. Obviously, since these folks are part of our community, if there's somehow a follow-up that you really feel like you need an answer to, we probably can do a little email and get at least a little bit of an answer back and forth from some folks. So please shoot those to me at my email if you need to, and I'll try to forward those on. But thank you all for participating.
Well,
Wear masks, right? Wear masks when you go out.
Wash your hands.
Wash your hands. Keep social distance. All right.
Right.
And
Hey,
even
Darren?
into stage 2, 3, 4. Yes.
Darren, I saw a poster from 100 years ago, and
Yes.
it said, wear a mask, wash your hands, keep a distance from other people.
Even
What's
as we
changed?
move forward, there are some things that will stay the same, and so I'm glad that knowledge is with us and continues to be good for us. So thank you all again. God bless, and God bless each of you that are participating. Thank you all.
Okay. Thank you, Darren.
Bye.
Bye, y'all. I'm gonna